Okay, good morning, everybody. Thank you so much for joining our 8th Take a Stand for Caregivers CEU webinar. My name is Robin James, and I serve as the Development and Marketing Director for Middle Alabama Area Agency on Aging. And this is a very special class, and I want to thank our keynote speaker so very much for joining us this morning, and that's Dr. Rita Jablonski and Jeremy Rains. And then I will turn it over to them after I just give about 5 minutes of my little spiel about just going over some of our programs, services, and special initiatives. Dr. Jablonski is a professor of School of Nursing at UAB. She's also a nurse practitioner working in the Memory Disorder Clinic. Rita works very close with M4A and some of the other local area agencies on aging specific to Alzheimer's and dementia. She is a very well-established researcher, and she's received funding from several different very large federal funders to support her research efforts. Dr. Jablonski is also a fellow for the American Academy of Nursing and Gerontological Society of America. And Dr. Jablonski has over 50 peer-reviewed publications that she's put out. And so we were very delighted to have Dr. Jablonski join us this morning. The second speaker is Jeremy Rains, and he is with our agency. He serves as the coordinator for our Alabama federally funded Alabama Cares program, which he's going to go over with you all this morning. Jeremy grew up in the Wiregrass region, and he came from one of the larger local area agencies on aging, which is headquartered in Dothan, and they cover a 7-county area. He also works closely with me on different initiatives, but he serves as the lead trainer for our dementia-friendly law enforcement and first responder training, and we've gotten some national recognition for that program. We just recently got a national award, and Jeremy and I pretty much go into fire station kitchens, and well, we did before COVID, sheriff deputies' offices, police departments, and we train them how to be dementia friendly. So thank you both so much. I also want to recognize Carlette Smith. She is our CEU provider for all of these classes. And here you can always go to her website at humanresourceoptions.com, and she will be providing the 1.5 CEUs for this morning. So thank you very much, Carlette, for your partnership. We have 2 more classes coming up, and one is December 2nd, and it's long-term care advocacy and resolutions for residents. And then the other one, we did switch the intellectual and developmental disability class till January or February of next year. Our 2 speakers had a date conflict with the December 16th date. So I, myself, and another partner we will go over Take a Stand Against Elder Abuse. And okay, just as a reminder, because we do have some new attendees on the webinar this morning, the AAAs, or the Area Agencies on Aging, operate in every county in the country, and so anywhere that you are or a loved one resides, you can be rest assured that you have access to a local AAA. For Alabama, we operate in all 67 counties. There's 13 local area agencies on aging, and so we are one of 13. Our overall mission is to help individuals of all ages to age in place within their community. So every area agency, including M4A, we have what is known as an Aging and Disability Resource Center. And that really serves as a single point of entry to receiving and being screened, properly screened, for all the programs and services that someone may be eligible for. We do specialize in serving older adults, but keep in mind our youngest client is 9 months old with autism. So we do serve people of all ages at all stages of their life. There's one really easy number to call to be automatically connected to your local area agency, and that is 1-800-AGE-LINE. And so these are just some of our core programs and services. A lot of people know us as Meals on Wheels, but it's actually a federally funded elderly nutritious program. And then we have a lot of home and community-based services, which is our Medicaid waiver. Right now, as you probably all know, it's Medicare open enrollment, and all during the year, we do free Medicare counseling. And that's really one of our popular programs because we help a Medicare beneficiary navigate all of their coverage. We even have a back 1-800 number for the state health insurance program to Medicare. So the beneficiary doesn't even have to be on the phone. Our Medicare counselors can just call 1-800 Medicare and help with that coverage issue. So we also have a state-funded prescription assistance known as Senior RX. And Jeremy's going to go over our caregiver support program. A lot of you who have been on these calls have heard from Jan Neal, who serves as our legal service provider. And so she does free, non-fee generating legal help if you're 60 and above. Next, on December 2nd, we'll go over our long-term care ombudsman program. And we also have a senior employment program, and we do cover that in Jefferson County. And so it's real easy to just make a referral to our agency. If you don't want to pick up the phone and call, you can always click that lime green button on our homepage. And it's just a very simple process. And we just want to make sure that if somebody needs some sort of help, that we screen them for everything so that they don't slip through the cracks and only get a meal when actually they're also a caregiver and they can qualify for our caregiver support. So I just wanted to spend a minute or two just going over some of our written resources that we have that we would love to have you all help us distribute these in your, through your family and friends or through your profession. And one is called The Book. We've passed out thousands and thousands of these, and this is about a 26-page book that just goes over more in depth all of our programs and services. And then it also gives some tips like signs of a heart attack and just other really good information for consumers. Our most recent is, we just came out with this. It's a guide for healthcare workers. And it's just a real simple little book, square book. And again, we can put these, I can get these in the mail, or you can make arrangements to pick them up in Alabaster, whatever works for you all. But it really will help us promote all of our programs and services that we have available. This is a statewide, it's known as the A4A brochure, which stands for the Association of Alabama Area Agencies. And this has a map with all the contact of all 13 offices and just more information. And so this is just part of the brochure I just put on the slide. This has been very popular, and it's called Project Life Connect. And we came up with this in 2000, I guess, late 17. We have a lot of financial support for this program. And what this is, it's magnetized on the refrigerator, and those insert cards, it's what hospital do you want to go to? What are your list of your medications, who to call in case of an emergency? There's just all kinds of very simple things that, and we train first responders to look for this in the home. And so all of our clients have this, but there's no cost to the consumer, and it costs us about $1.40 a piece. But this has been really life-saving. People will bring this to their doctor's offices if they have to go to the emergency room, and it just gives a good snapshot for the first responder or the doctor or physician, or the discharge planner, really, to just have all that information in one convenient location. So again, if you can help us distribute these, we just got another order in, and we'll make arrangements to get them to you. So just another brand new initiative through our PANDA project that, and Jennifer Fuller is on the phone with us. She provides our IT support. So thank you, Jennifer, for being on these CEU classes. But this is actually a federal program, and it's called Brain Health and Aging and Administration for Community Living. Actually came up with this curriculum, and we are just starting to roll it out. And our first class, it's a Zoom free. There are no CEUs, but this is just really for seniors and the public and anybody who wants to learn about the basics of brain health and aging. And so this is going to be a really good initiative that we're just now starting. So thank you, Jennifer, for that. And here is our contact information. And if you have not signed up for our newsletter, it goes out 1 to 2 days a week, and it'll just keep you connected on what's going on across the aging network. So with that being said, I'm going to stop sharing my screen, and I'm going to turn it over to Dr. Jablonski.
I'm sorry, was Jeremy going to go first?
No, I think either one. I think we had you set up to go first.
Okay, no problem. Hi, I'm Rita Jablonski, and today's talk is Preventing and Managing Care-Resistant Behavior. So the first thing people say is, what is care-resistant behavior? And really, care-resistant behavior is any behavior that the person with dementia does to refuse or resist care. Unfortunately, it's often called agitation, but that's not the same thing. So let me move to my next slide. I also have a Facebook and a blog, Make Dementia Your Bee, and I put a lot of this information that I have in today's talk is also on the blog and on the Facebook page. The Facebook page is Make Dementia Your Bee. The blog has the naughtier word in it, but I have the clean URL, makedementiayourbee.blog. That also goes to the same site, and that's the URL I give to patients and family caregivers, and that's what appears in the chart. Oops. So, I want to talk a second about what is dementia. It's a global term, just like you have car and then you have different types of cars. And what dementia really means is a chronic progressive loss of cognitive abilities. But the cognitive abilities are more than remembering what today's date is or remembering who was the president of the United States. It incorporates your higher executive functions, which involves judgment, managing finances. It also involves what's called your non-declarative implicit or procedural memory, which is a fancy way for saying how to do things. I don't have to think about how to tie my shoes or get dressed every morning. I can do it while I'm thinking about other things. But if I had dementia and as my dementia would get worse, those very simple automatic type tasks become much more difficult because your executive functions also intersect with procedural for things like sequencing. Currently, 6 million people in the United States have some type of dementia diagnosis, and the number is growing. And if you took all the people who've ever had a breast cancer diagnosis and people with opioid addictions and combined both, they would still not exceed the number of people with dementia. And dementia also involves the efforts of 15 million caregivers, providing close to 20 billion hours every year and $230 billion in unpaid care. So let's meet the dementias. There are many different types of dementias. There's the Alzheimer's dementia, which people are most aware of, vascular dementia, which is due to both to symptomatic strokes, or some people have strokes and have no symptoms, and it's not until we see cumulative brain damage that they start to exhibit evidence of dementia. You also have Lewy body dementia, where people start off first with some fluctuating changes in cognition and progress to, and also some issues with memory. And then they start to have movement disorders. And the different side of the same coin is Parkinson's disease dementia, where people present with movement disorders and over time develop cognitive impairment. You also have frontotemporal dementia, which is most known for the behavioral variant type. And there's also other combined dementias. You have multifactorial dementia, where you can have pathology from 2 or more different presentations. The most common we see is a person with vascular dementia, and Alzheimer's. People with old head injuries develop what's called chronic traumatic encephalopathy, and you also have unusual or rare presentations such as cortical basal degeneration, or what's called some of the Parkinson's plus and tau pathology presentations as well, such as your primary progressive aphasias. So getting back to vascular dementia, all the dementias result in some type of brain shrinkage. What's very interesting about vascular is you can see, and my arrow is pointing to these little hyperintensities. Now, some of the hyperintensities you see around the ventricles in this MRI image, and the MRI is the person is laying down, and here's the forehead, here's the right side, here's the left side, and here's the bottom of the head. So it's as if I'm standing at the foot of the person's bed and chopping their brain in bread slices. And see, these hyperintensities are they are merely artifact from the MRIs. And actually, unrelated to the hyperintensities here, you do see some degeneration of the parietal lobes and even some of the frontal. So this person has atrophy and also has vascular dementia. In this second one, you can see we classify this as moderate. The hyperintensities are starting to come together or become confluent. And there is a scale, a phasicus scale, and you may read in the chart, someone is a phasicus 1, a phasicus 2, or a phasicus 3. This is severe, where the hyperintensities have become very connected, and it's wiping out entire networks. And I'm going to have to apologize if you hear anything in the background. My cat decided to join the presentation and wants to like climb over the computer. So oftentimes you'll pick up a chart, or the family will say, well, my family member has mild cognitive impairment or mild, moderate, severe dementia. What does that mean? Mild cognitive impairment comes from, it's defined from a consensus between the NIA and the Alzheimer's Association work groups. And it's defined as a change in cognition in any domains of cognition reported by either the patient or a significant other. Plus, there is objective evidence in impairment in one or more domain, which could be executive functioning, concentration, attention, short-term memory, visual, spatial. However, these individuals are independent in their instrumental activities of daily living. They are still paying bills. In some cases, they are still working without any noticeable deficits. The DSM-5 calls this mild neurocognitive disorder because the DSM-5 just likes to give everything a new name. And MCI does not automatically mean dementia is coming down the pike. And then there's also amnesic versus non-amnesic. The non-amnesic people aren't asking you to repeat yourselves. They may show problems in, for example, executive or visual spatial, where those with the amnesic components are the ones who may ask the same question a couple of times in a conversation. The levels of dementia are mild, moderate, and severe. There are the FAST scales, which are based on Riceberg's global deterioration scales, and you have 1 through 7, and in some cases you have like 5A or 7A. That just gets crazy. That's great for like a home health situation or for a research situation when you're trying to quantify interventions, or for home health, you're trying to get someone qualified for hospice or for some type of benefits. But in the world of the caregiver, it doesn't mean a whole lot. So in our clinic, we tend to use mild, moderate, severe, and treat it as a continuum. So mild includes episodes of forgetfulness that progress to confusion. The person may complain of their own subjective realization that they are experiencing memory loss, but not all the time. And the person may engage in what's called circumspect speech. Instead of me saying, please hand me the pen, I will turn to you and say, please hand me the, the thing you write with. That's circumspect speech. They may misplace familiar objects. Now, before everyone is sitting here thinking, uh-oh, that sounds like me, you may be stressed out beyond all levels of previous stress. This is 2020. And if it can go wrong, it does go wrong ×3. So if you can trace your steps and say, where did I put my coffee cup? And then go back and trace it and find it, you're okay. People can also have difficulty remembering new material, such as names or a new computer program. Now, again, if you are stressed out, you are having deficits in concentration and attention, which can cause these same types of symptoms. Moderate, the person starts out oriented to person, place, and time, but they do need some assistance. For example, you see the deficits in the instrumental activities of daily living. This person can't do online banking anymore, or is having problems balancing a checkbook, is not remembering appointments. They may be dressing inappropriately. So wearing, a very light summery outfit on a day like today, or putting on a heavy overcoat when it's August and 100 degrees. May have trouble remembering their date of birth or address and do become overwhelmed in new environments. People tend to be in the moderate stage of dementia the longest time because moderate encompasses such a wide range of deficits. Severe is the last stage, and these individuals cannot live independently. These people require assistance anywhere from prompting for activities of daily living to actually receiving full assistance with daily living. There is also something called cognitive abulia, and that is the loss of willpower. And what that means is the individual cannot hold on to a thought long enough to determine a purposeful course of action. That's why people with severe dementia may sit somewhere and maybe fidget with an object or just seem to engage in non-purposeful action and seem unable to, say, hold a cup or do a very simple activity of daily living because they just can't hold on to the thought long enough. So now I'm going to talk about the why behind the what. In other words, what is going on with the brain that causes you to see certain behaviors that contribute to care resistance, and what can you do about it? So at this point, and this is what I call the fun part, the brain on the left is the brain from someone who died with some type of dementia. Notice the brain has shrunk. There are the gyrus or the gyri, the grooves, and then you have the spaces in between called the sulci. The sulcus or sulci become much more exaggerated, and there is much more space between each individual gyrus. When you look at the healthy brain on the right, there's very little, there's some space between the gyri, but the gyri are literally touching each other with minimal space. So when I talk to family members about short-term memory loss, and that contributes to care-resistant behavior, I compare the brain to a box filled with items that I've collected over my lifetime. At the bottom of the box are things I collected as a child. On top of the box are things I've collected more recently. As my brain shrinks, the stuff that I collected most recently falls out, whereas the things I collected in my childhood or even early adulthood rise to the top of the box and now are more accessible. That's why people with a dementia cannot tell you what you told them 2 seconds ago, but can tell you a very complicated memory from 1972. That's also why it's difficult to create new memories, because my box has shrunk and it's already full. So if I were to take those objects and try to squish them into the box, I would have limited success. I do have a caveat here. Just like if you're packing to go away and you have a suitcase, if you are bound and determined that you are going to go away for a week and you're going to shove everything in an overnight bag or a carry-on, if you shove things in hard enough, you can probably fit a week's worth of clothes and cosmetics and shoes into a carry-on with enough force. Now, I'm not going to guarantee that the carry-on bag is going to make it to the, once you get off the airport, it's liable to explode. But if you try hard enough, you can do that. The same way with memories that are very emotional. If there's enough emotional voltage around a new situation, the person with dementia can create a new memory. That's why you have someone who may be highly forgetful, but they know there is a great-grandchild coming. So what this means is loss of current memories plus access to older memories actually creates a new reality for the person living with dementia. That's one of the reasons why you get the same question or topic over and over again. My family members call it the hamster wheel. That's also why you get care refusal. I just had a bath. What's happening is the person has a memory of taking a bath, and it's an old memory, but because of the shrinking brain, the memory feels like it just happened. So they're going to tell you, well, I don't need to take a bath. I just took one. Meanwhile, they haven't had a bath since election day, but no sense arguing. Or the person will say, well, I don't need any medicine because they are living in a time in their life when they really didn't take any. So the people are moving backwards in time. And I will talk about strategies. Well, actually, I want to talk about strategies right now. So some of the things that family members and clinicians do, especially I see nursing assistants do this in nursing homes, it makes me get very upset, is people quiz the person with dementia. Now, come on, Mrs. Smith, I took care of you yesterday. You know who I am. Let's face it, if I don't know who you are and you keep insisting I do, at some point I'm going to get irritated and I'm going to become care resistant, or I may just haul off and hit you. Another trigger that family members will do is they will use the verb remember. Now, come on, Dad, remember you had a doctor's appointment? Now, Mom, remember this is the neurologist. If you want to create a behavioral disturbance, use the word remember repeatedly. It was hard for me to do this, but I have removed remember from my vocabulary when working with people with dementia. Logic does not work because, again, you have the shrinking brain. The brain can only hold on to a few thoughts. So I go into this paragraph-long logical explanation of why you need to take a bath. It's only going to escalate the behavior. And arguing doesn't work. And here's an example I get a lot from physical therapists. I've had physical therapists take care of an older gentleman with dementia, especially if I have a younger physical therapist, maybe in his or her, well, in this case, it's a her, mid-20s. And the physical therapist is really upset because the 80-year-old man with dementia who's married and has umpteen children, grandchildren, and great-grandchildren is flirting with the therapist, may even attempt to touch her breast and buttocks, and she's upset. Well, what I tell the therapist is this behavior may be fueled by loss of memory. He's moving backwards in time. So he thinks he's 18 years old. He may have forgotten he's been married. He doesn't know he has grandkids. And also the frontal lobe is shrinking, so there's a lack of impulse control. So the way to approach this is to calmly say, no, I don't like that. And be careful about bringing it up to the family, because the family's not going to know what to do about it, and they are going to be mortified. And you may want to consider assigning a male therapist or an older female. Those types of persons with dementia. So I'm now the older female they assign. So the next thing I want to talk about is nerve traffic in a healthy brain. In a healthy brain, this is what your thoughts are looking at, your neurons are doing along pretty well. However, in a person, all of you by about mid-morning or after your third Zoom meeting, your brain looks like this. You have a lot going on. You have a lot of thoughts. You're trying to multitask. Your brain is like the interstate at rush hour. This is what happens in a person with dementia's brain. The neural networks may be interrupted. So you do have functioning at one end of the brain and functioning at the other end of the brain, but the pathway is interrupted. So what happens is the brain and the body loves duplication. You rarely have just one road in your neural network. You usually have multiple routes in a neural network. But just like 280, just like 65 may be faster than 280, and 65 is definitely faster than Route 31. As the person with dementia progresses, that's where you get the cognitive slowing. 65 is closed down, so the person is now rerouting onto 31. But if you put that person in a new situation, that's like 65 being shut down at 8 o'clock in the morning and all the commuters flooding onto 31. You will get there eventually, but it's going to take a while. Another way to conceptualize the brain is the brain is divided into compartments. You have the different lobes like the frontal, parietal, temporal, occipital, and even sections inside of the brain, the midbrain and so forth. And all of those compartments are clearly defined and have their assigned tasks. And the compartments are highly organized, and they do communicate with each other, but the thoughts are somewhat, again, compartmentalized. So if I have a memory, that memory is deconstructed so that the emotional part of the memory is in one part of the pictures of the memory is in the occipital part, smells are in the entorhinal complex, and so forth. And if I want to bring up a memory, all of those components are rapidly assembled, and here's my memory. That's one of the reasons why music and smell can trigger memories from a very long time ago. They go through a different pathway and start to thread together the memories by a completely different pathway. That's why you can have someone with advanced dementia who was a a musician or a dancer, and if you put the person in front of a piano, he or she may be able to play Chopin or Schubert. Or if a dancer hears a certain piece of music, may start to dance because that memory is buried deep in the compartment and you just went another route and accessed it. In a person with dementia, the compartments become somewhat messy. So memories are all over the place. So this is what my son's room looked like before he finally got a real job and moved out. Yay! So here you see like the dog someplace. There it looks like chemistry homework. You have random things all over the place. So if I were to go in and there's the cat hiding in the drawer. So if I were to come in here to look for an item, I wouldn't know the first place to look for it. And that happens in dementia. The memories can get somewhat convoluted and mixed up. So what you get is you get what people call the tall tales, where the person with dementia will start to tell you about a trip they took to Fiji, and the family member is standing there looking at you and shaking their head. The person may have read a story about Fiji and may have another memory about going on a cruise, and somehow the experiential memories of going on the cruise become combined with memories obtained from seeing movies and reading books, and you get what's called the tall tales. Another aspect of neurodegeneration that does contribute to irritability and to care-resistant behavior are the loss of functional neurons all doing their jobs. Imagine you have a shortage of colleagues because they're quarantining or they're sick with COVID. So you go from having a large group of people to staff your unit or staff your home health agency, and now you're down to this many. So what happens is you may have brand new graduates that you recruit to kind of inflate the numbers, but this brand new graduate doesn't really know your system. So you are trying to do your job and orient the new person. Plus you're taking on tasks that you haven't done in like 3 years. So you're sitting in front of the computer trying to remember how to put in a certain type of order. In the beginning of the shift, you may be okay. By the end of the shift, you're going to be exhausted, irritable. You will have made mistakes. You will have neglected to do things. This is what happens in the brain of a person with dementia. As the neurons die off, the remaining neurons are doing 2, 3, 4 times the amount of work. The brain tries to recruit other healthy neurons into existing neural networks. And so the existing neurons are trying to chemically train the new neurons into how to do something. So their neurochemicals are getting depleted, just like you're getting tired orienting the new person. And what happens is the person with dementia may be fine in the morning, but as they become more fatigued, or if they're in environments with a lot of stress, with a lot of cognitive load, they become increasingly irritable and will refuse care. So to summarize all of this, all of the neurodegeneration I'm talking about results in slow retrieval, which can be overloaded in complicated situations like Thanksgiving dinner with 20 people around the table that we're not supposed to be doing. People become lost because even in homes they may have lived in or neighborhoods they may have lived in for 10 or 15 years, because as the brain cells die off, maps are forgotten or they are combined. I've had the lived experience of moving frequently in a 1-year period where I moved from Pennsylvania to Alabama. So I moved into a rental house, and then that rental house was put on the market. I didn't want it, and I wasn't ready to buy. So I moved into a second rental house, and then I bought a house and moved into a third. My kids wanted to kill me. So within like a 3 to 4 year period, we moved 3 times. And by the time I got into house number 3, where I am now, I will still walk into the kitchen and use my left hand to turn on the light, because that light switch was there in the last 2 houses. It's not there in the current house. So my maps have gotten mixed up because I have moved repeatedly in a short amount of time. The same type of thing happens with someone who may have been in their current living situation for 5 or 10 years. They may be getting lost because they're going back to their living situation from 20 years ago. That also explains why someone who's been in the same house since 1962 and they're now 80 years old, they're doing just fine, because even though they're moving backwards in time, that map of the house is ingrained. It's like burnt into the brain. Also, people can come adrift in memories, and this explains the changed meaning of time. As I lose more and more of my short-term memory and I'm losing my context, I am not aware of time passing. So that explains why I'm caring for someone with dementia. I go to the bathroom, I come back, and the person with dementia looks at me and says, "You've been gone for hours." Or I call the person up, or I visit the person every day, and the physical therapist walks in, and the physical therapist is told by the person with dementia, "No one ever comes to see me." The person isn't trying to get attention or being difficult. They've lost their context, and they're also losing more and more of their short-term memory. They're not recalling what happened that day or even the day before. It's a lot like a boat without an anchor, where if you go out to sea far enough, you can't tell where there's land, and you may not know what's north, south, east, or west. So another thing that happens a lot is sometimes the person with dementia may make sexual or romantic gestures toward an adult child. That is not pedophilia, that's a mistaken identity. And I'm going to use this example. This is a picture of me with my 80-year-old mother and my younger sister, and this is my niece, Lauren. And we got together a couple years ago for a family picture. So this is a picture from 1969. And if you look, this person looks just like Lauren. This chubby little child is me in 1969. And this is my niece. So if my mom were to develop dementia, she may look at my niece Lauren and call her Rita. And the same thing can happen with adult children. I am amazed at how much my one daughter looks like my sister Ann. And there have been times it's taken me by surprise. And I've actually called her Ann because she's a dead ringer for my sister at that age. My son looks exactly like his father when his father was that age. So if I had dementia and I looked at my son, I could easily mistake him for his father. And I may look at his dad right now and look at this, 62-year-old man and maybe think that older man is my father. So that's where some of the misidentification comes from. Another thing to be really cognizant about is caregiver vibes. I have people I work with, and they walk into a room and the room just lights up and everything's great and they're so positive and wonderful. I love working with them. Then I have people who walk into a room and I want to take Xanax and Effexor and anything else I can get my hands on, because they suck the air out of the room. They are just so negative and so blech that everything just leaves. Those are vibes, and we actually have nerves that their only job is to literally pick up vibrations. So YouTube has a lot of great, and I've used this with caregivers to explain how emotions are contagious, both good and bad. So if I take a tuning fork and I thump it and I hold it in front of you, at some point you will no longer hear the tune and you no longer see the vibrations. But if I put it in water, it will displace water because it is still vibrating. I just can't detect it with my eyes. And so this explains why if I'm a caregiver and I'm upset or anxious about getting to a doctor's appointment, I can increase the anxiety of the person with dementia and trigger care-resistant behavior. So in my own clinical practice, I will stand outside of a room or in between telemedicine calls. I take a few deep breaths to kind of center myself so I don't bring any emotional debris into the clinical encounter. And if you think this is trippy, dippy, hippie stuff, think about the last time you were in a code and all you need is one person panicking and the entire code team goes down the commode. So another trigger for care-resistant behavior, especially in the moderate to severe stages, is what's called the neurobiology of threat perception. This is usually the point in the presentation when I'm live where I jump and I go, rah, and I scare everybody, but Robin turned off my camera so I can't do anything cool. And I'm really upset because I actually put on makeup and did my hair. But anyway, we won't say anything more about that. But what you have here is this little thing called the amygdala. The amygdala's job in the brain is to act like a smoke detector. In that, with the smoke detector, if my smoke detector goes off, it means dinner's ready or I have a blazing fire in my house. The other, I have to stop and assess my environment and say, oh, dinner's ready, or no, holy crap, there's a fire in here. Let me grab the animals and run out. In dementia, this amygdala continues to fire repeatedly, and the parts of the brain that inform the amygdala and say, no, this person is taking off your underwear because you peed, or this person is putting a stethoscope under your blouse to listen to your heart, not to be rude. Those parts of the brain have either shrunk and aren't doing their job, or the connections have been interrupted. So the amygdala is like the smoke alarm going off and there's no context. So what this means is people with dementia tend to misinterpret caregiving situations as a threat. So they can't tell the difference between a helping action and a harming action, but there are ways to work around this. So another thing to think about are illusions. Illusions are something we all do. We all look at something. Is this a dog or a cat? Well, if you said cat, you see two blue cats. If you said dog, you see the dog eyes and the cute little dog nose and then the dog ears. So with neurodegeneration, if I have dementia, I may look at a household object and I may see something else. And ways to get around that is to make sure the eyewear prescriptions are up to date and clean, keep the area very well lit to avoid shadows, remove clutter, and reassure. And I want to give you a great example. Here's some tile I saw at Lowe's. And I thought to myself, this tile I would never get because I could see a face in the tile, like here's the nose, and then I could see a duck. So maybe I need a site consult, but there are examples of heavily patterned tile and carpets that even those of us with no diagnosed cognitive impairment can see images, and it can be kind of weird. So the person with dementia may also do the same thing. Hallucinations are a problem. They tend to be more prevalent in Lewy body dementia, but can occur in all of them. It's important to respond to the emotions and concerns that the hallucination is triggering. I've had people with dementia whose hallucinations involved pets or children, and they were comforted by the hallucinations. I've had people who were terrified. So the handling of the hallucinations depend upon how the hallucinations are perceived by the person with dementia. Just something to think about: medications that make movement issues better may make cognitive problems and hallucinations worse. So it's a good idea when there's hallucinations going on to review medications, especially those with effects involving the central nervous system and with anticholinergic properties. So environmental interventions to handle some of these illusions that you can also use to prevent care-resistant behavior is to close the curtains and shades when it's dark outside, because residents may see distorted reflections on glass and think someone is in the room or waiting outside to attack. And also be aware of shiny reflective surfaces, because people may think the floor is wet, or I've had people see their own reflection in TV screens and mirrors and report to family members that there's other people in the house. So it's important to determine if the source of the stress is a true hallucination or is an illusion or some type of misperceived environmental stimuli. So preventing and managing the behavior. The rules of Dementia Land, to recap, are: the meaning of time changes, logic does not work, caregiver vibes are contagious, respect the adult, and behaviors are ways of coping that make sense to the person with the memory problems, even though they don't make sense to us. So general caregiving strategies: first, no elder speak. Elder speak is a tendency for healthcare providers and others to speak to older adults with high-pitched baby talk. I receive elder speak every time I walk into an electronics store. Hi there, what can I help you with? Oh, you want to buy a smart TV? And in spite of my age, I'm pretty darn good with technology, so I have to restrain myself from engaging in harmful behavior to the lovely person at Big Buy. But in healthcare situations, I see nurses, physicians, and other clinicians doing elder speak constantly. So mind yourself and do not engage in that behavior. Because Christine Williams is a well-known researcher. I think she's in Florida now. And she has an entire body of research in which she has demonstrated that nursing assistants who engaged in elder speak were highly likely to be hit by a person with dementia than those who did not. It's also important to speak with a lower pitched voice, because our ability to hear high-pitched sounds decrease as we age. It's also important to encourage as much self-care as safely possible, because that will reduce triggering care-resistant behavior. Use one-step respectful commands. Please pick up the soap. Please wash your arm. Also, and I'll get into this in a second, it's really important to use gestures and pantomime, because people start to lose the meaning of words. Smile when you interact with people with dementia, and this is really hard with masks, and I think it's why care-resistant behavior is becoming more problematic in home health and in other places where masks are being utilized, because I can't look at a person's face and check out the emotions. Positive rewards, when possible, help to create emotional positive memories. So, bridging is one strategy where you give the person with dementia a related object so that it triggers procedural memory and it helps reduce care-resistant behavior. And that's good if you encounter it. See, she hands over the toothbrush, and that's related to the mouth care that she's trying to do. Another important strategy is chaining. Chaining involves the caregiver starting the caregiving activity and allowing the person with dementia to finish it. It also a little bit of hand over hand and some gentle movement. You may need to add gesture and pantomime to it, but you get the person started and then you let them take over. That's a good way to prevent care-resistant behavior. Distraction is a big one, and singing has been found to be highly. This is a true story. Even though these are actors, I had a woman with dementia who would only brush her teeth if I sang "I've Been Working on the Railroad." And one time I stopped and she hit me in the head with a toothbrush. The student nurses thought it was hilarious. Now, hand over hand technique, whoops, excuse me, sorry, my PowerPoint is nice. Is a way to put the person with dementia's hands over yours while you do care, or you can put your hands over theirs while they're doing something. And that gives the sense that they are controlling the situation. So if you're encountering argumentative or refusal behavior, a lot of times, it's triggered by best intentions, where the staff is saying things like, remember, or they're trying to use logic. Your approaches are consistent schedules are a caregiver's best friend, both in the home and with formal and informal caregivers. Schedules, we teach children schedules to create procedural memories. We implement schedules to support and maintain procedural memories in people living with dementia. Caregiver moods are contagious, so when possible, try to watch your own mood. Address sensory deficits, make sure the eyeglasses are clean, the hearing aids are free of wax, and they have a fresh battery. Use a smiling, gentle touch approach, short one-step requests, and no elder speak. Also, pay attention to low levels of care-resistant behavior, like people starting to turn away or push you away, or starting to get fidgety or say no. I've watched combative behavior escalate when the nursing assistants, they are bound to determine they're going to brush that person's teeth or they are going to give that person a bath, and the person with dementia is starting to resist and pull away. And the CNAs don't have a repertoire of skills, because what I'm teaching you has not been inculcated into the CNA curriculum. It should be by now. It's been out since 2010, but I got nothing there. But anyway, the CNAs are only taught distraction and come back later. And that's like saying, I want you to do home repairs, and here is a screwdriver, and that's it. You're not going to be able to do a whole lot with that. So for CNAs that I've taught these techniques to, they recognize lower levels of care-resistant behavior, and they start jumping in with chaining, bridging, hand over hand, distraction. Well, no, they've already known distraction. Or they'll incorporate other techniques that I'm going to show you in a second, and they keep the care resistance to low levels, and it doesn't escalate. When you are encountering argumentative and refusal behaviors, apologize. This works so well. I've walked into a person with I had this happen in one of my telemedicine visits, where the camera went on and the person with dementia was quite put out because she did not know she had an appointment today. And she started fussing at the daughter, who started arguing with mom. And I immediately jumped in and said, I am so sorry. I did not send out the reminder. This is my fault. As soon as I apologized, the person with dementia said, oh, okay, because that's part of the social cues. If we're upset about something and someone acknowledges, oh, I am so sorry, that was my fault, we tend to settle down. And gestures and pantomime can also be incorporated with when you're telling people what to do. because the ability to understand the spoken language diminishes as the dementia progresses, especially when you have temporal lobe neurodegeneration. The temporal lobes hold on to the dictionaries. So as you hear my sounds, your temporal lobes are interpreting my sounds into meaningful words. So if I were to start to speak Klingon, for example, I would fathom to say that the majority of you would hear nonsense and it would not make sense. Whereas if I launched into Spanish, many of you would understand or would at least recognize, oh, that's Spanish, and you would pick out some words depending on your knowledge of Spanish. As the temporal lobes degrade, the ability of the person with dementia to connect the sounds that they are hearing to the dictionary are compromised, and the dictionaries themselves are shrinking. So it's as if pages are being ripped out of the dictionary. So certain sounds lose all meaning. And I have had this happen in clinic where I've said to someone, starting at 40, count backwards by 4. And the person looks at me and says, I don't understand. Draw a clock. What do you mean? If I break it down to draw a circle, put numbers. What numbers? Because they already lost the word clock. So that's why complementing your spoken word with gestures and pantomime can help with communication and help derail argumentative and refusal behavior. I talked about distraction. Asking for help is a good one. Can you help me by putting your arm here? Helping works really well, especially with adult children caring for parents, because oftentimes the adult child is saying to mom or dad, Mom, do this, Mom, do that. Well, mom or dad may forget many things, but they'll never forget they are an adult. And they may become upset that who is this person telling them to do things? And it's a reversal of the role. Instead, if I say, Mom, help me, please, that triggers that deeply, deeply buried and very resilient response as a parent to want to help. And all of us, whether or not we're parents, we all need meaning and we all want to help. So that's a really good strategy to get around some of these behaviors. Many of you have maybe heard the term white lies, fiblets, and therapeutic fibbing. That's when you lie to the person with dementia to achieve a specific aim. A long time ago in my career, I saw no problem with this. However, in the past 8 years, about 8 years ago, where I was interacting with a person with dementia, and she kept asking me, where's my mom? Where's my mom? And I just said, oh, she's at the store, because I wanted to get the care finished. And somehow a certain set of neurons lit up, and the woman looked at me for a split second and said, my mom's been dead for 20 years, at which point I felt completely terrible. The next day, I went in to provide care, and the dynamic was very different with this person with dementia. She couldn't tell who she was. All she said was, I don't like you. So somewhere in her midbrain, in her diencephalon somewhere, she connected my image with the emotion of mistrust. And somehow that neuron made a connection. She could not articulate the whole context, but I had messed up. So what I embrace now is entering reality. First of all, it's a different vibe than lying. And so there's also, you avoid the consequences of getting caught, and it opens up the communication. So an example of entering their reality is you really have to know the person with dementia, or you open up communication in a more questioning manner, which validates, and some of this is built on validation therapy by Naomi Fail. So the person with dementia is saying, I want to see my mother, and mom has been dead for 40 years. So instead of me saying that, I simply say, tell me about your mom. What color are her eyes? I speak in the present tense. What is your favorite thing about your mom? And that may be an opportunity to reminisce. And sometimes what happens is I start to uncover an emotional concern that's being conveyed. So I want to see my mom. Our moms are usually our emotional havens. You know, when things go wrong, who do you call? Your mom. I had to laugh with my adult children. I was a village idiot when they lived with me. As soon as they moved out, I became a genius. And so now that my children live away, they will call me regularly with, hey, Mom, I wanted to ask you about, my boss at work is being a real turd. Can you help? Yes, I can. So it's been a lot of fun. So for me, so what I realized is when people say I want to see my mother and I start to talk to them about mom, or I hear I want to go home, what I may be hearing is I'm frightened. The things aren't making sense. I am scared. And then I can react. Also, entering their can provide a reason to do something, where you tap into their previous jobs or roles. So I had a person, a family caregiver, call me because her mother would not remove soiled clothing. And I said, okay, so tell me about your mother. Well, my mother worked as a domestic for years. And I said, okay. So the first thing she started to do was she said to her mom, Mom, we need to do the laundry so you can get paid. Well, that tapped right into mom's experience. And mom said, well, sure, I need to get paid for doing the laundry. And the daughter said, great, I don't have enough to make a full load. Take off your clothes that you're wearing, I'll have a full load. And mom said, why get paid? And daughter said, yes. Mom took off her clothes, daughter did the laundry, and she paid mom a quarter. And mom happily, first she was paying mom in dollar bills, but then mom was hiding the dollar bills. And then I suggested paying in change because it's easier to find the quarter when you vacuum it up and you can hear it. So last I checked, daughter's been using that for like over a year. And when the granddaughter came home from college and went into the laundry room to do laundry, grandmother was quite upset because doing laundry was her job, even though she really wasn't doing the laundry. She was getting paid as the laundry was being done. And she kicked the granddaughter out of the laundry room because the grandmother said that was her job and she wanted to get paid. So we didn't expect that. But that's where you can be really creative and work with families to come up with legitimate reasons to do something. You are not lying, you are entering their reality. And it also gets rid of a lot of morality. So I have a puppy, and this is what happens when I leave Amira alone for any length of time, which is why she's at daycare. Actually, this isn't my puppy, but she has done this in my house. So people who are bored get into stuff, and boredom is a big problem with people with dementia. So that's where those of you who are physical therapists may be able to help family members with activities or to do physical therapy during times that you don't normally do it, to keep people with dementia moving and active and alleviate boredom. Music is great, but it needs to match preference and outcome. And as we are having younger and younger people present with dementia, it's okay now to play Rolling Stones and Jimmy Buffett and things like that. And even Pink, find out what they like. It's good to match, make activities safe to match with pre-dementia preferences, such as helping with chores or what's in the toolbox, or other ideas I've had, have been gardening was something one of my relatives enjoyed. And what I recommended was we created a garden out of plastic containers and put them on the back deck so that she could plant in the tubs and still engage in gardening activities. And it was a lot safer than her walking down the stairs or off the deck to the backyard and digging in the backyard. So anyway, this concludes my presentation. I am going to stop sharing my screen so that Jeremy can do his thing, and also if there are any questions.
Thank you so much, Rita. And everybody, while Jeremy's getting his set up, we will go ahead and put the evaluation that you need to fill out within 24 hours to get your CEU in the chat, as well as I'll show a slide. So I'll turn it over to Jeremy.
Yeah, there's been a couple of comments we noticed where we had some professionals send their information. So just if you follow the information that Robin puts out there, it will get you everything you need to do to get that CEU. So thanks again, Dr. Jablonski, for that awesome presentation. That's not just tips and tricks. That's tested and tried true methods that she's used. So definitely pass that information along to those of you who are professionals who work in this field every day to definitely utilize that in your own job and career fields. Thanks again. And of course, with M4A, we have numerous programs in our office, but one in particular is our Alabama Cares program. So I wanted to take a few minutes to kind of go over who we are, what we do, and how we might be able to help either you personally or you as a professional if you have clients who are going through some of the situations that Dr. Jablonski mentioned. So again, my name is Jeremy Rains. I'm the Alabama Cares Program Coordinator for M4A. The Alabama Cares Program was created back in 2000 by way of the National Family Caregiver Support Program initiative that was created by the Older Americans Act. For the state of Alabama, we've named the program the Alabama Cares Program. It is a Title III caregiver federal funded program. And of course, it's housed in each of our 13 area agencies on aging that Robin went over towards the beginning of this presentation. So we of course cover 5 counties within our region. That is Chilton County, Shelby County, Blount, St. Clair, Walker counties. So if you, for any of those regions, of course, we kind of cover those areas. Now, of course, we do have this across the state of Alabama. Individually for our region, it may be ran a little differently than it is maybe in some of our sister agencies, but overall, the program really serves the same purpose. All right. So who is eligible for Alabama Cares? It has traditionally been for individuals who are caring for a loved one. If you're 18 or older, caring for a loved one, 60 or older, or individuals who have a dementia-related diagnosis of any age. If you're someone 18 or older caring for someone with dementia-related diagnosis of any age. And then we've always had as well older relatives, which was basically individuals who are either a grandparent or an aunt, or you have some type of legal custody of an individual 0 to 18 with or without a disability, but you have to be 55 and older. Recently, in the last few years, they have opened that up to include individuals aged 55 and older who are providing care to an individual 19 to 59 with a severe disability, and that can include parents. So we've kind of got the full spectrum here of ages as that's a concern to try and help any way possible. So, of course, the types of service that we provide are, of course, similar in the name, but as you could expect from someone who's caring for a grandchild versus someone who's caring for someone 60 or older, or maybe someone with a severe disability of any age is really, or 19 to 59, of course, is going to be a little bit different of a service than we provide across that, for someone who might be caring for, say, a grandchild. Okay, so Alabama Cares is commonly, there's a misconception that we're mostly just a respite and supplies program, but I did just want to kind of go over the services that we provide as a whole to try and, provide you all with more insight on what we do outside of just respite and supplemental services. So these are the core services that we provide, kind of our basic building blocks of our program. And those are caregiver information, caregiver access assistance, education and counseling, and then of course, supplemental services and respite services. With caregiver information, that's really just information that we provide to the public, not necessarily registered or what we call registered caregivers with our program. It's really just information about resources that are in the community. We do several workshops throughout the year during normal years. We do, webinars through Zoom with some of our other programs in-house or with other community partners. So that's really just information that we put out to the public to try and make sure we get resources to caregivers that need it. Caregiver access assistance, of course, is an individual service for caregivers that we provide to registered caregivers through our program, but we really look at that as mostly just a case management type service, and really we get questions all the time about, whether there's a food bank in my area, whether there's a resource for this, or what should I do in this situation. So it's really just general case management that we provide to our caregivers who we have registered in our program. Caregiver education and counseling, we approach this from many different avenues, but typically, if you have a caregiver that needs education on a certain topic, we have a lending library, or we can provide educational material. We also do support groups. We do one-on-one counseling with our caregiver interventionist, who is Ms. Crystal Whitehead, who couldn't be with us today, but she can provide some of those a little bit more, kind of intervene on the situation to provide more of a one-on-one type counseling, as well as partnering with partners such as Dr. Rita Jablonski to kind of help for more of those severe cases. We also partner, which I'll go over in just a few slides, but we partner with some of our other in-house programs to provide webinar type programs. We also do a virtual support group, which we have a flyer in a couple of slides. So we provide counseling and education in many, many more formats than maybe just educating the caregiver directly on one particular topic. We also provide, of course, supplemental and respite services. These are both temporary. They've kind of always been this way. I know sometimes there's a misconception on our program, but our program as a whole is a temporary service, so we're only able to provide up to a certain amount of money to provide both respite services and supplies. And of course, that's based on the highest need, and it is based on the funding that we receive for the program year. Our program year is what we call a fiscal year. It runs from October the 1st through September the 30th. So we just started fiscal year 21. And of course, it is based on the funding that we have available, depending on how many people and families that we can serve. Of course, supplemental and respite services are our two paid services. So they're a little bit more strict than some of the others. With respite services, of course, you really need to you need to help provide, ADLs, IADLs, a little bit more in depth about things like Dr. Jablonski went over with things like bathing, whether it be homemaker services, assisting with walking, preparing medications, meals. There needs to be a little bit more in depth, but at least 20 hours of unpaid care per week. So those are, of course, like I said, temporary, and we utilize different tools to hopefully provide those services to those with the highest needs first. I did want to touch a little bit on our grandparent older relative caregiver program again. Again, like I said, with the traditional side of things, we provide services through local organizations, or what we call direct service providers, as well as there's a kind of a self-directed means that we can provide through a company we partner with out of Huntsville, where you can actually pay someone privately who's 18 and older that does not live in the home, and then you get reimbursed for that service. But traditionally, we have direct service providers that can come into the home. We're ever evolving with our respite end. We're trying to potentially reach out to adult daycare facilities, as well as other organizations, to do maybe less of the in-home and more of in a community type setting. So that's something that we're working on. But of course, that's more of the traditional end. With our grandparent older relative caregiver end, respite may look a lot differently. That might be come through things such as after school care, summer camps, extracurricular activities, different training events and things. There's always weekend summer camps. So we try that from a different angle. It's still the same service. There's still the same intent there, is to provide that brief relief and respite care for the relative caregiver, to kind of give them a break to go to the doctor, do their own errands and whatever the case may be. So that the intent's still there to provide that respite. It's really just a different type of respite service. And then, of course, we also provide supplies. Again, this is temporary, so it really just depends on the funding that we have available for our specifically dedicated to this portion of the program. But we can also help with clothing during the holidays, or really, back to school, as well as school supplies. This year has been a really important year for us to try and get maybe some of those non-traditional school supplies like laptops and different things to really connect the kids and keep the kids engaged during the pandemic, as well as things like anything like that really that supports that eases the financial burden for the caregiver. So clothing and school supplies are really our two big supplies. But of course, there may be things like band dues, extracurricular activities. Like I said, if there's a specific athletic program, we might be able to help cover some of the costs to help pay for that program. Because really, mostly what we focus on is this a service that, does it give the caregiver a break, or does it complement the care of the grandchild or the great nephew or whatever the connection there is. But most importantly, does it build character? Is it a positive influence in the child's life? So that's really what we try to rationalize and justify to provide those services. Kind of goes through the same process. Ms. Holly Thacker runs this program. She's our special projects coordinator, but she does her due diligence in trying to really help those with the highest needs first. But we seem to, this is an ever evolving program as well, and we're definitely getting plenty of referrals through the pandemic. So this has proven to be a really life-changing and great program as well. Wanted to touch a little bit on our ACEs program. This kind of goes along with Ms. Crystal Whitehead. Again, she couldn't be with us today, but she utilizes this program, and it stands for active caregiving empowerment skills, and it teaches skills to manage stress more successfully, change, prevent, interrupt difficult behaviors, as well as teaching and practicing mindfulness, allowing the caregiver to be present with their loved one in a more meaningful way instead of just moving from crisis to crisis. It's a 4-week evidence-based informed seminar, 2 hours per week, that teaches skills to improve difficult communication situations by teaching healthy ways to communicate with doctors, nurses, residential staff, as well as navigating difficult hostile family relationships, such as a relative that does not understand their loved one's diagnosis, behaviors, and care needs. All in all, ACEs lessens the burden of caregiving by changing the caregiver's approach to and view of caregiving. Some of the other things that we provide, like I said, with our education and counseling sessions, we also provide a virtual support group. We do have a disclaimer there because this is open to the public, as it would be if we were in normal circumstances. Our office door, we do these in-house during, again, when our office is open during normal years. We've switched that over to virtual now. Of course, we do that through Zoom, and it's the second Thursday of each month at 10 a.m. and you're more than welcome to join us. You don't have to be a registered caregiver. You don't really have to be eligible. If you're 54 taking care of a grandchild, well, you can still join Holly's support group. She does one as well. You don't have to necessarily fit the criteria to get the paid services to join our support groups. We're still there to offer as much support as possible if you need it. Also wanted to touch base on the coffee break sessions, which we will be having this afternoon. Currently, these are probably about to be restructured just a little bit, but right now we're doing them every other week, and this is a collaborative effort with the Panda Project, who Robin mentioned earlier, Ms. Jennifer Fuller, who runs our Panda Project. We provide these services as really just a brief respite for caregivers. You don't have to be in a specific county or have a specific diagnosis. The intent of this program is really just to provide in a similar format as these, in a webinar type format, to really provide viewers or participants with a brief hour of respite to take a break and quit thinking about caregiving so much for an hour, as well as provide them with a new resource or program that's within the community. With this session of coffee break that we have this afternoon, it's from 1 to 2, typically every time we do one. We were going to have a presentation on mindfulness to really, to kind of take that break and tie into really the health of the caregiver, and remembering to take time for yourself and care for yourself, because of course, if something happens with the caregiver, who's going to take care of their loved one. So that's really what we're trying to do, is provide that brief respite and you really connect them back to a resource. So if you want to know more information about that, we have a Facebook page for both our Panda project as well as M4A and Alabama Cares. We place these on our Panda Facebook page. It's under our events. So just if you're interested in that, it kind of has an RSVP link to any of those. We put those, of course, we record them and we put those on our YouTube channel and we make those accessible. So if you can't make these, but you're still interested in going back and listening to them, we put them all on our YouTube channel so that you can learn more about those resources. Other programs I kind of wanted to highlight quickly was our True Alta program, as well as T-Care and MailChimp. With True Alta, it's basically a tailored system that Crystal Whitehead, again, the caregiver interventionist, utilizes to, we post our YouTube videos in there. She puts other resources. Caregivers, we have a limited number of spots, but caregivers can utilize that program to tailor resources and information and different, low cost, no cost health and safety tricks and, just general information and education. They can tailor it to the individual that they're caring for. Like if they're caring for a loved one who doesn't have dementia, but they have Down syndrome, it can be kind of tailored to that. So that's a great asset, as well as T-Care. And the Panda program really uses T-Care a lot, as well as Crystal uses it occasionally with some of her more severe cases through her intervention. And it basically takes the caregiver on a journey, I guess you could say, to tailor that. The T stands for tailored. It tailors the resources and the aspects of that caregiver's life to really try to focus on the most. You may be worried more about the health of your loved one more than you are your own, and it can kind of pinpoint areas of your life that you can focus on the most, to have the most kind of put your energy towards that, to have the biggest impact. So that's a great software that's ever changing that we're utilizing through our office to really hopefully continue to increase the quality of care and kind of evolve the way that we deliver care. And then, of course, we have a newsletter. Panda has a newsletter. Alabama Cares has a newsletter for our participants. We also have one for M4A. So we're always putting information in those newsletters that go out weekly to try to connect caregivers back to resources, as well as let them know things that are happening both legislatively as well as in our local communities. This is our Alabama Cares staff again. Again, my name is Jeremy Rains. I'm the Alabama Cares Program Coordinator. There's my email, as well as Ms. Crystal Whitehead, the Caregiver Interventionist, and Ms. Holly Thacker, who's our Special Projects Coordinator. Of course, all of our phone numbers are the same for our office, but if you can ask for us specifically, they'll get you back over to our extension. And then there's our M4A website. If you go to that directly, that'll get you to our Alabama Cares page. And we try to keep that updated with different things that are happening, any type of programmatic changes, as well as resources that we think are that need to be on there. And then, of course, like I said, we're on Facebook as well. So you can follow us at facebook.com/M4AAL Cares. We're always trying to post positive outreach and uplift, as well as, just different things that are happening throughout our community. So feel free to follow us on there. And that's really all I have. I don't know if there's any questions. I don't see any. Again, if you have any questions as far as the CEUs, Robin, do you want to touch on that a little bit?
Sure. I'll go ahead. If you can stop sharing your screen, I'll pull the link up. And
there you go.
Okay. And let's see. And then Jennifer will put it in the chat box for us. Okay, there it is. There's the link, and you can always go to humanresourceoptions.com, and it's just a simple survey monkey that Carlette Smith would like you to fill out, and she will quickly get you your CEU certificate. And I wanted to just take time to thank both of our speakers today. It was just a wealth of really good information. I've been a caregiver 4 times, 3 of those with some form of dementia or Parkinson's. And I'll tell you, I wish I would have known the tricks of the trade back then. So thank you so much. And we stand ready to help you and assist you in any way that we can. And we hope that you will join us December 2nd. So I know we have a minute or two for some questions, if anybody has any questions.
And of course, if you have any questions, even at a later date, I mean, we're streaming this live on Facebook. So if there's any questions that that come out of this. If you drop a question on the video, we can still see it. We'll still try to get back in contact with you and get you in contact with any of our staff that might be able to help out.
And we did record this, so if any of you are interested to share it with other staff or any of your loved ones, we are more than happy to send you the link when it becomes available. And you can always, I guess, just email Jeremy or myself at rjames@m4a.org. Well, since there's no questions, thank you all so very much. Have a wonderful Thanksgiving holiday, and we'll talk to you soon. Thank you so much.
Thanks, everybody.